Really my pleasure always to introduce Dr. Mahalaxmi, a well-known, very well-known personality in India and abroad as well, and a beloved teacher. So Dr. Mahalaxmi Sekhar, she completed her post-graduation in conservative dentistry and endodontics in 1986 from Government Dental College, Ahmedabad, under Gujarat University. She has been in academics since 1990. She is currently heading the Department of Conservative Dentistry and Endodontics at SRM Dental College, Chennai, and since March 2006. She has more than 50 publications to her credit, and she has authored a textbook titled Materials Used in Dentistry in 2013, which is highly acclaimed by faculty and students all over country and abroad. She also has DST funded collaborative project under her wing to the tune of 39.34 lakhs, for which she is the principal investigator. She is a registered PhD supervisor and under SRM University. She was awarded Professor J.W. Kannappan Award for the best research article published in IJDR in 2016. She was the president of Federation of Operative Dentistry of India for 2008-2009. She is currently an international board member of Academics Microscope Enhanced Endodontics. She has been a speaker in various national and international forums and has conducted various workshops. So we welcome you, Dr. Mahalaxmi, and we are really waiting for your fantastic presentation as always. Thank you. I think it's on mute. Yeah.
Thank you so much, Sucheta. It's always a pleasure meeting you anytime, anywhere in the world. And a very good morning to all. I would like first, I will share my screen. Okay, here we go. So at the onset, I would like to thank Dr. Smita, Dr. Shekhar from Sri Sai College of Dental Surgery, Vikarabad, for inviting me for this wonderful program. Mine being the first lecture and the topic given to me is management of badly broken down teeth. Okay, so I am actually going to talk about both the pre and the post endodontic restorations because both are really very important. So what is the goal of our endodontic therapy? Is it only to remove the microorganisms and to and their endotoxins to render the root canal free of them? Or is it something more? Is it to render a long-term functional retention of that tooth in the oral cavity? So that should be our main goal. So our goal of endodontics encompasses both the removal of microorganisms as well as to restore the tooth to its original form and function. Now, this very, you should say, landscape study by Ray and Trope, they have given way back in 1995 the role of coronal restoration in the endodontic success. Okay, they say that even if your root canal treatment is insufficient, you still, if the coronal seal is good, then you still get about 68% of success. So see the role of a coronal seal, how important it is for the long-term success of an endodontic therapy. Of course, when you have everything done perfectly, you're close to 90%. There have been a lot of studies on these the presence and the absence of periapical lesions, the Washington study, the Kakehashi study in 1965, Sundquist in 1976. They all have reiterated that removal of microorganisms and a coronal seal both are essential in preventing reinfection of the root canal. Now, there are other studies as well, a lot of other studies where they have stated that, for example, this study by Tronstedt et al. In 2000, there is a slight variation in the success rate, but there's still, they say, if the quality of the coronal restoration is poor, your endodontic success is diminished. Sorry. And as I said, there are other studies by Looney et al., Saleh Rabi et al. They all have stated the same thing. So, what do we have in mind? When we talk about restoration, or when we talk about any restoration for that matter, the first thing that comes into mind is the normal, how much of normal tooth structure do we have? And here is where we talk about minimal invasive. So minimal invasive is not only in restorative dentistry, it also has come into endodontic therapy as well. So what should we do as dentists, as endodontists? Our aim is to minimize any damage to the tooth structure, right? So we need to maximize the natural tooth structure and minimize the damage that we do to the tooth. Now, when we talk about minimal invasive endodontics, it's a new, relatively new terminology, which was given by Nassé, Trope, and West in 2016. And they say that not only prevention of pulpal and periapical disease, management of pulpal and periapical disease, but in conjunction with the preservation of tooth structure and the supporting tissues. So it is a sort of a balance between too much and just not enough. So too much tooth structure loss, or would you, compromise on the removal of tooth structure in wanting to preserve enough of tooth structure? So this has to be a balance, because if you do not say remove the full the roof of the pulp chamber, or if we do not do a proper cleaning and shaping, we may end up in a reinfection. We may end up in not removing the microorganism totally, which we do not want. So that there should be a subtle balance between what is too much and which is not enough. So let's see all these x-rays, a lot of x-rays here, just to show you that, there are different types of cases that you will come across in your clinical practice, right? So invariably, with proper diagnosis, almost all of these will go for endodontic therapy, but their restorative options varies, right? Right from a minimal direct composite restoration to an invasive techniques wherein we need to rehabilitate the entire tooth structure. So there is innumerable ways in which it can be done. So though the endodontic therapy is the same, the restorative options varies tremendously. So what should we have before we even start the endodontic treatment? We should always keep the end in mind. So we need to focus ahead and see how our restorative option will be when we see a particular case, when the patient comes in, walks into your clinic for an endodontic therapy, and you do a diagnosis of pulpal or periapical lesion, and you would like to go in for an endodontic treatment. From that time onwards, we need to make sure that your restorative option also is determined there and there. Generally, we tend to, do the endo and forget about the restorative aspect. Now, here is where we need to be very careful. So, my lecture today will be basically, focus on two aspects. One will be the pre-endo, that is, before you even start the endodontic treatment, what you should do, and the post-endodontic treatment. And of course, why should we forget something in between also? during the endodontic therapy, how we can preserve tooth structure in a way that it will help our long-term success or long-term retention of that tooth in the oral cavity. So just see this particular case. Sorry. Now, what do you think is the problem with this? Right? Can somebody actually? Okay. I'm not able to see the chat box. Otherwise, I would like to have some, you know, interactive session. I wanted somebody to tell me what exactly is wrong. But then when I clicked, all my options came off. So see, if you see such cases, I think routinely you'll be seeing such cases. Generally, because our Indian people, they don't come to the dentist unless it's very late. So you have such situations wherein you have this isolation is a problem, you have temporization will be a problem, it will get recontaminated, your irrigant will not be there enough for you to have a proper lubrication and its action. So multiple problems you will encounter in cases such as this. So what we should do as an before we even start, actually that particular case that I showed is an sorry. This particular case that I showed is mine, but I just took I generally do all the endodontic therapy under rubber dam, but this is a post endodontic restoration. So you can see how much of contamination is already happening. So obviously we have to do the post endodontic restorations also under rubber dam. And this photograph is just to show you how much compromise we are doing in terms of treatment aspect. So we need to just assess the tooth before we even start a treatment. So now you see this particular tooth, a seemingly intact tooth, but the patient gives all the symptoms of a periapical lesion, and you take a radiograph. I'm sorry, this is not the actual picture of this particular tooth, but I couldn't get this, so I'm just showing you a similar situation where you may actually end up. You may see a seemingly intact tooth, okay, and when you take a radiograph, this is what you see. Now, what do you think this tooth? Is it salvageable? Now, according to me, no. You probably may try and do a hemisection and a radisection, remove this part of the tooth and retain the nasal half. But the aspect here is that we have to take into consideration is the periodontal condition and also the root caries. So two aspects which will tell us that no, this tooth should not go for a root canal treatment. Now, many times it so happens that we just see the X-ray and decide. In this case, it is a straightforward case. Now, what if sometimes you get something like this? Now, this is actually a patient which I saw just yesterday, and just by seeing this, you see that almost half of the tooth is gone, right? And in this, of course, with the proper illumination, I could see that caries is going much subgingivally. So my first thought was that okay, I don't think this can be done salvage directly. Probably we'll have to do a lot of crown lengthening procedures, do some period treatment and so on. But when you see the radiograph, see here. Now see the radiograph, the caries is actually, though it is subgingival, it is much above the alveolar crest. So probably if you do a proper removal of the caries and build up, you probably will be able to do a routine, probably conventional root canal therapy for this patient.
But we have to keep asking.
I request everyone to please mute yourself. Thank you. Okay, now these type of cases is X-rays will definitely tell you that okay, this is close to the gingival to the alveolar crest. There is root caries. Apparently, when you remove all these caries, you will end up with the fracture of this particular route. So you probably would think of, hemisection or extraction and implant. So I would say, like, as an endodontist, we are the best persons to tell which tooth goes for an implant or not, right? Now, another simple, I would say, an photograph for you to see. This also is a subgingival caries, right? And a previous restoration has broken and lodged in. And the radiograph, if you see, is not so simple. If you see, the caries is extending almost up to the alveolar crest. We should always keep in mind that whenever we do a restoration, it generally should be the best option would be, or the ideal situation would be, supragingival, right? Supragingival margins. And this is right on the alveolar crest. So your biologic width is definitely being compromised. So in this case, though it looks like a simple, straightforward case, it would definitely require crown lengthening procedure, wherein we remove a little of the bone, take this alveolar crest to a lower level so that you have about 2 millimeters of gingiva over it, and you can bring the margins to the supragingival or at least equigingival level. So this you have to ensure so that you have the patient is able to maintain a maintain better, and so that the long term success of your endodontic therapy in terms of retention of the tooth also is better. So we first talk about our pre-endodontic management. What all we need to do. Now, as I showed you some of the cases that the situation that you may encounter, what will you all what we can do is, one is that we can do, and suppose you are not, if the tooth structure is not adequate, we can do a multiple teeth isolation. We can modify the clamp, and the gingival clamp, sorry, the clamps can be placed more gingivally on impinging on the gingival tissues. Though it is, as periodontists, they will probably come to kill us, but at least the gingiva will, heal after a day or two. And also, we can build up a tooth with the help of any band, which may be a copper band or an orthodontic band, or you can even give a temporary crown. And of course, wherein there is biologic width is being compromised, we have to do a crown lengthening procedure. And in case of crown root ratio, which is also not favorable, then we may need to do an orthodontic extrusion, because orthodontic extrusion generally brings down the alveolus and the tooth as well. So your crown root ratio will become more favorable. And also, canal projection is one method in which you can manage pre-endodontic management of teeth. Now, one technique that we modification of our rubber dam is the split dam technique. Now, if you all notice everywhere that isolation is the key, right? We have to isolate properly. Rubber dam is a must. I know routinely after, probably because of the pressure from your professors and staffs, you during your PG days, you use a rubber dam and then stop using it once you go out into your clinical practice. But I'll assure you, I have been using rubber dam. I have been using rubber dam only for the past 13 years, though I've been practicing for around 30 years. But I would say it's really a godsend now. I cannot practice without rubber dam anymore. So if you see everywhere, that is the key. And now isolation is the key. Isolation is where you can get away with small variations in your cleaning and shaping, because you are providing a very clean atmosphere for the tooth to revive itself. So in this case, if you see, this is a split dam technique. You can use it without the rubber dam also, and without the clamp. And you can use a floss and to tie it so that the dam doesn't slip out. You could modify, and you can use a different type of, say, for this, for example, in a anterior, use a premolar clamp, or in a premolar you can use an anterior clamp. So the sky is the limit for any modification that you would like to do. So only make sure that it is this comes with practice. You will not know immediately. You may say that it's difficult to use a rubber dam, but with practice, rubber dam just takes about 30 seconds or so, maximum 1 minute. So I think the amount of time that the patient spends in getting up and spitting out and talking and moving his tongue in the way, all this. Thank you. Instead of that, replacing a rubber dam, taking time to place a rubber dam is much better, because ultimately you save a lot of time. Now, in case of multiple teeth, this is one case that I had done in my clinic. I had used a split dam technique also, and I had applied, see in the previous x-ray, if you see, it was this in the anterior, its upper anterior is fine, because this will not have any salivation coming over, because nicely tucked, a heavy rubber dam. But with the rubber dam sheets that we are, getting in India, getting a heavy rubber dam is a little difficult. So the routine sheets that are available, you could actually use your flowable composite, or you have your bleaching. Along with bleaching, you have this gingival seal that comes. So that material can be used. The flowable resin material will be used, and you can do a proper isolation around the teeth. And this was a particular case where, if you can see, there is hardly any tooth structure left. And after the removal of the post and the old restorations and all, placed a calcium hydroxide, and I could get a decent obturation done. And if you see this during the post-endodontic restoration, this is what the remaining tooth structure was. So ideally, when we start the root canal treatment, the first thing we need to do is remove caries completely. Sometimes we always stand up, like if you remove caries, the tooth will become too weak and it will break. So we tend to retain some amount of the caries as well, caries tooth structure, so that we have some tooth. But what happens when you inter-appointment? When you call the patient after a week or a month or so. So what happens? The tooth will fracture. So you make sure that every first visit, as soon as the patient, you start the endodontic treatment, you have to remove caries before you even enter into the root canal orifice. Okay, so after this, post was placed, and this is the final preparation for a crown. So I would say I could manage a fairly decent restoration, and I'm sure that this restoration will last at least for 10 years, if not more. So this was immediate. This patient is due for checkup soon, and this was done in 2015, and she's in the US. So she keeps telling every now and then that I'm coming, and she never turns up. For the other types of the modification that you can do to the clamp is that, as I said earlier, is to use an anterior clamp for the premolars, or you could use remove a wing for one of the clamps and to accommodate additional clamp. And also you could sharpen the prongs of the clamp to facilitate its placement. See here, for example, this is a tooth. The premolar doesn't have any tooth structure at all. So the clamp was modified. This clamp is, we cannot place a clamp here because this adjacent tooth is clamped, and the wing of this clamp is coming in the way. So what you do is you just cut off the wing and then make a way for the next clamp to be put in. So this way, this modification can be done for teeth in which you cannot have any retention for retention of the rubber dam without any clamp here, because the tooth structure is inadequate. There is no proper contact in that tooth. And of course, use of a band. In case of, again, a badly mutilated tooth, you can use a band, orthodontic band. It can be even copper band. We used to have copper bands when we used to study long back. I don't think we get it anymore. but you could use orthodontic bands, and then it can be in place till you finish the root canal treatment. Or you could use an automatrix or any band that you normally use for your class 2 restorations, and do a proper build up and make the tooth isolation of the tooth much more effective. Now, when we talk about all this, another option is to do a gingivectomy or a crown lengthening procedure. So in this particular case, I used a laser to remove all, and you can see now the actual height is well enough, and I could achieve a decent circumferential removal of the gingival tissues. Another main, one of the main what you can say is that these are the canal projectors. So this actually, we can modify it. This has been proposed by Dr. John Munz, and he actually, in this particular thing, you need to identify and locate all the canals, remove all the caries, and then you need to place these canal projectors. These are plastic tubes that are available, different shapes. Then you introduce it along with the reamer inside the root canals, and then use an autopolymerizing injectable composites, or any material can be used. Glass ionomer can be used, composite resin can be used, but the best is to use a dual cure or chemical cured composite, so that once you inject it, it should be injectable in nature, so that once you inject it into it flows in everywhere, and you get a proper restoration with the projection of each canal. So each canal, when you project it, each canal, when it's projected, you know exactly which canal it is, say the distobuccal, the MB1, the MB2, and the palatal. Now, there are a lot of advantages of this technique. Basically, it is to, it elongates the canal, so that, obturation and all that becomes, cleaning and shaping and obturation becomes easier. But the main disadvantage of this and the others are that you do not have adequate space for your volume of irrigant. Now, that is where you need to be, whether we need to have really these alternatives, or you would like to have a pre-endodontic buildup. Okay, so what is a pre-endodontic buildup? It is to build up the coronal part of the tooth structure, so as to enable you to have a box-shaped access cavity. Now, this box-shaped access cavity is very effective in many ways. It will help us to, to locate the canals. It will give us a map. It will show us the floor of the pulp chamber properly. It will help in preventing bacterial contamination from the caries. If you remove the caries and do a proper restoration, you will not have bacterial contamination during the procedure as well. It also prevents irritation from the irrigant leaking out from the sides. You have the class 2 lesions, wherein you directly try to do a root canal treatment. Even with rubber dam application, the patient starts screaming every now and then that it is hurting, or it is it feels odd, because the irrigant is actually leaking into the oral cavity. And also, when you restore the tooth, you will get a stable reference point for your working length determination, and to maintain that working length during your cleaning and shaping procedure and during your obturation. So, and also it prevents inter-appointment contamination. That is my I would not say micro leakage; it will become a macro leakage. So it also prevents leaking out of the intracanal medicament that you place into the canal. So the main thing is, another main aspect is that when you do a proper pre-endodontic build-up, that is, do a proper adhesive protocol, you remove the caries completely, isolate it well, and do a proper restoration, then this improves the prognosis of your endodontic tooth in terms of, sometimes what happens that sometimes the patient, you give an appointment very late or the patient doesn't turn up, then the tooth is at least you have, the prognosis for that tooth being in that place is much better if you do a proper pre-endodontic build-up. Now, the main requirement for a pre-endodontic build-up, what is it? Is that once you do the restoration, you should be make sure that the pulp chamber is very properly visible. Or in some cases, when there is total calcification and you do an endodontic, pre-endodontic restoration, it should not make it difficult for you to locate the canals. And it should also mimic the natural tooth structure, so as to as I said, it will provide a guide for the access cavity, and it also should have able to last through the entire root canal procedure. It should provide support for not only the rubber dam clamps when it plays. It's once the rubber dam clamp, the impinges on the restoration should not drop out, and at the same time, it will also should support for temporary restorations that you keep over during the root canal procedure. So for this, what we need to do is to see how much of tooth structure is lost, how much is remaining, and we choose the most conservative option. Now, a simple case in this case, see this, it is a distal cavity. Now, generally, what is the tendency is whenever we see a lesion, a caries lesion, a tooth, we tend to start from here and try to do the access cavity from here, which is a bad idea. We should not do it. Sorry. The if you see this is did the proximal cavity separately, did a proper restoration, and then went on to do access in the normal conventional way. And this is post-op. This was 2016, and this was 2018. And you can see the restoration is fairly good. The proximal restoration is fairly good, but I'll have to take another radiograph later and see how it is right now. But then you can, when you do a proper restoration, you can be assured that the tooth will stay for a longer time. Probably now I would not even do a crown. I would rather do an onlay or overlay, as you call it, or try and include this in the. I tried to include this in the restoration, but then in the crown, but then it was too deep subgingival, so couldn't manage to do it. Or a simple, glass enamel restoration, remove the caries, do a glass enamel restoration, and do a access cavity right from the central pit. Right now, there is another technique which is called as the donut technique. So it's actually a modified donut technique, you can say. Keep a band or anything, and you make a sort of a donut around the tooth to support the tooth circumferentially. The main aspect here is to remove all the caries, to remove any unsupported enamel. All this has to be removed completely, so that when you do a restoration, not only does the restoration stay in place, but also there is no fracture of the chip off of the tooth structure as well. Okay. So this is very important, and removal of caries right from the gingival seat as well. If you can see here, and if you can manage to place your clamp and a proper wedge here, and you're able to isolate it, then you can go ahead and do your bonding procedure. Or else we can do what is now called as the submarginal elevation of the margin, by placing a glass ionomer restoration at the end, at the gingival seat, or a flowable composite on the gingival seat. And one more case report by from our own country by Dr. her name, I don't know, Dr. Shalini and her student, I think her name is Shrishti. Their case report in which they have done this modified donut technique, and see how nicely you get a box-shaped cavity of the axis, so that whatever irrigant that you use has to be in that pulp chamber for a long period of time for it to act. The sodium hypochlorite that you are going to use will have to stay. It will act as a lubricant. It will not leach out. It will not cause irritation to the patient. So a little effort towards doing a pre-endodontic buildup is always better than to directly go in for a endodontic procedure. Now, now that over to your during the endodontic treatment part. I hope I am not okay. I think I'm a little late. I'll do a little faster now. So what happens during endodontic treatment? Of course, this doesn't hold good for badly mutilated teeth, but make sure that whatever tooth structure we remove, it is the bare minimum to it is required to have a great proper access to the apex, right? So we there is a lot of other techniques that for postgraduates, as a postgraduates, you need to know. So wherever we can preserve as much as marginal ridge, oblique ridge is better. And where we can remove less roof chamber, roof of the pulp chamber, which is called as the soffit design, and also use a proper preoperative diagnostic aids, not only of radiographs and CPCT, and also during your procedure, use of a microscope helps in a long way. Now, why do we stress so much upon retention of the tooth structure? Now, this nice article about the effect of restorative procedures on the occlusal loading and the or on cuspal deflection. Okay, a premolar tooth, which is having that is having a maximum cuspal deflection. So this particular study, they did a mean cuspal distance between two cusps, and they found it to be 99669 microns, and from that they started applying load. Okay, once they started applying load, they 50 newtons load, 100 newtons load, 150 newtons load, and they found what was the deflection of these cusps. So in case of unaltered teeth, you can see it is only in 0.3, and as it increases to 150, it came to up to 2.6. Right now, when it is a conservative cavity, for example, it's an MO cavity, then when it as it the cavity extensiveness increased, you can see that the values also increased, the cuspal deflection also increased. Now when you have an endodontic axis, you can see, and when both the marginal ridges are involved, you can see the amount of deflection that the cusps have. It is phenomenal. So such is the the impact of an endodontic axis cavity on the teeth. So that is the reason why we need to be more careful. And this current concept of the pericervical dentine, which is about 4 millimeter above and below the alveolar crest, this dentine, the circumferential dentine, which is 4 millimeter above and below the alveolar crest, is what is called as a pericervical dentine, and that helps a lot in the stability of the tooth. And this tooth dentine is supposed to have been preserved. So that is the reason why now straight line axis, at least to the coronal aspect of the tooth, is now not in vogue anymore. Now, of course, now with all this ninja axis and all that coming into play, this is a very nice article by Plotino and Grande, who have seen the different effect of these different cavity designs on the fracture resistance of the teeth. And they saw that and they found that the conservative axis cavity and the conservative axis cavity and the ninja axis cavity, they are supposed to actually reduce the fracture resistance of endodontically treated teeth. And ninja access cavity is supposed to reduce it even further, because it's almost a very minimal preparation. But they show that these both have similar fracture strength than the conventional, of course. So the ultra conservative endodontic access cavity did not increase the fracture strength of the teeth. So we need not compromise on the proper cleaning and shaping in order to provide enough tooth structure. But of course, compared to your conventional, a conservative access cavity is what we should keep in mind. Now, moving on to the post-endodontic restorations. Why do we have so much? We talk so much about post-endodontic restorations when any restoration is the same, right? Now, that the reason for that is because there is a lot of variation between teeth with vital pulp and a tooth which is root-filled teeth, right? So one is that there is a lot of loss of tooth structure, right? Right from caries, whatever we have to remove, old restorations that we remove, and the endodontic access cavity that we prepare. Also, the use of all these chemicals, such as the irrigants, the sodium hypochlorite, EDTA, the calcium hydroxide that we use as an intracanal medicament, all these have a bearing on the stability or the strength of the dentine, the radicular as well as the coronal dentine. Now, what happens to that, we will discuss now. There is a lot of changes that happens within the collagen within the dentine. Now, on top of that, the tooth with its natural tooth with a vital pulp has a lot of proprioception. It has the ability to sense the occlusal load, whereas when it is a pulpless tooth, then it becomes the level of proprioception is greatly reduced, so that it is not able to withstand, or it's not able to compensate for the heavy occlusal forces that are acting on it. And also there possibility of a post-treatment disease when following endodontic treatment. Now, this is a Bible article that you all as postgraduates need to go through, the mechanisms and risk factors for fracture predilection in endodontically treated teeth by Dr. Anil Kishan in endodontic topic. And the best part is that you don't take out any take home message from this article, it's fine, but the one thing that you need to all do to see is, or ingrain into your mind, is that first of all, do no harm, because the structure and composition of the teeth is perfectly adapted to the functional demands of the mouth, and they are superior in comparison to any artificial restorative material that we put into the mouth. So we should do no harm. And all these risk factors he has enumerated in the tabular in a table, in wherein you have the iatrogenic causes and the non-iatrogenic causes is what is more relevant to patients, because their demands are more. Patients with age, as they age, they have a lot of the factors that come into play. So these are the primary and the secondary causes: the history of recurrent pathology, effect of the aging of dental tissues, and the anatomic position of the tooth. So when we talk about dentine, we all know enamel is strong, but dentine is tough, right? So strength and toughness are two different aspects. When you talk about, but enamel cannot survive without dentine, because though it is strong, um, it is not tough because it's brittle. So it needs the dentine, resilience of the dentine to carry it forward, right? So when it comes to dentine, the main aspects, two aspects, right? One is the inorganic and the organic component. So the inorganic component is the one that gives it stiffness, and it contributes to the strength of the dentine. Whereas the organic one, which mainly type 1 collagen, is the one that I'm in a I'm in a lecture. Sorry for that. So type 1 collagen the main organic component of dentine, as you all know. This is theoretical, but it has to be true. So type 1 collagen mainly, and also non-collagenous proteins. And basically, when we talk about non-collagenous, we talk about talk about collagen. We forget about the non-collagenous protein because it just forms only 10% of the total collagen and the total organic component that is present. But these non-collagenous proteins, especially proteoglycans, are the ones that are responsible for the water content of the dentine. So this water is what they say that when in endodontically treated teeth, this water content reduces. But of course, it's not true. The moisture content is only lost by about 9%, and that is only the free water that is present, that is which is in the dental tubules. You probably can say because the pulp will provide some amount of hydration. Of course, that's true. But more important is the tightly bound water which is present within the fibrils. That is the in between the dentin, the collagen fibrils is the water molecules that are present due to hydrogen bond that provides the viscoelastic property for the dentine. So that plays a major role. It has this has the ability to withstand any stresses that are subjected. That is the reason why it is more supposed to be, dentin is more supposed to be more tough. So these are the considerations that you should have when you are actually doing a restoration of a pulpless tooth. So this another nice picture that is there in this particular article is this cross section of the canal, wherein you can see that the dentine which is around the pulp, because the pulp is a hydrated tissue, and this is the dentine surrounding it. This is dentine is more porous, more hydrated, and less mineralized, which is the inner dentine, whereas the outer dentine is the one which is more mineralized and less hydrated. So the pulp, the water that is in the dental tubules, it is held in hydrostatic pressure because of the pressure, that is hydrostatic pressure, which is there within the pulp space. So when we talk about restoration of endodontically treated teeth, we need to check all these as we did. All these have to be taken into consideration. What is the remaining tooth structure that is present? What is the length, width, the curvature of the roots, the occlusal function that has been, and which opposing dentition, how it is, the position of the tooth in the arch. Now this is plays a major role in whether to to use a post or not. Now, a very nice, category classification of the type of the teeth, based on which you can, whether to give a post or a core or post and core. All that is given by Perez et al. In 2005. They have classified it right from class 1 to class 5, depending upon the number of the walls that are present. So based on that, whether to give a post or not to give a post, and what type of post is preferred, what is the core material that has to be placed, all that is given in this nice article. And another later on, a newer classification of these is given by Zaro et al. In 2017. Again, they have classified, they have made it much more simpler, whereas they're just classified into 4. One is that very minimal tooth loss, so there is no post absolutely, only a composite core or any restorative adhesive core material, or an indirect restorative material also can be used. In class 1, wherein we need to give a post, whether it is fiber post or any other similar post. In the second or class 2 is where they have to do any pre-restorative procedures, wherein there is a lot of tooth structure loss. And class 3 is where you need to give a metal post, and gold cast post is what has been recommended. And class 4 is where the hoopless tooth which needs to be extracted. This is mainly due to periodontal and due to the periodontal status and due to the function and the position in the oral cavity. Suppose if you feel that a tooth by its retention, it is going to compromise on the overall restoration. Suppose it's going to be an abutment in a particular fixed partial denture, or it's going to be in a crown and bridge where you need to have this as an abutment, and you feel that it may not withstand the compressive forces. The main reason why there is so much of variations in the type of restoration that you need to do is that the molars and the anteriors and the premolars are subjected to different stresses that I will talk to you a little later. So this is a simple class 1 wherein you can do a composite core buildup, even if it is a class 2 restoration, provided that you have at least 3 walls intact. A class 2 situation wherein you have the bulk of the coronal tooth structure which has been removed due to caries, but you still have a rest the one wall intact. But then when you try to do a crown preparation, you will sort of lose the intact tooth structure, enamel and dentine around, so with nothing left in between. So in such cases, you can just do a fiber post restoration with a composite buildup and leave it like that. So this is the pre-op radiograph and the post-space preparation with the final restoration. So this if well finished and well polished, this will be your final restoration without any crown. Now, in case of a nice review article by whether you need to have a post and core and no post at all by Norman et al. In 2018. Now, they have taken about 15 cases where they have done this systematic review, and they found that there is absolutely no clinical evidence to support or reject the use of post, even for no wall cavities, which is either with direct or indirect restorations. So there you go. This is another older article which all of you have to go through for literature review on endodontic restoration of endodontically treated teeth. Dr. Richard Swartz has given a very nice review. And another article which I'd like you all to read is this article by William Chuang, which is in JADA. I think, can I have about 10 minutes more, Smita? Sorry, I think I'm a little, I'll try to finish.
Go ahead, ma'am. No issues, ma'am. Carry on.
Now, we as generally as dentists, we want to think everything complicated, right? So all this while you've been all hearing about ferrule. Now we have to make it little more. Every day we need something new to come. So latest advances. So this term has now come in as the 3-dimensional ferrule. It's nothing but a circumferential ferrule. You have to talk about the dentine, how much of dentine you have, that which is surrounding it, so that becomes a dentine girth, and the conversions that you're going to give in your cavity preparation. So let's just see a little on that. So it's just nothing but the height of the dentine, the thickness of the dentine. This remaining dentine that is present is what gives you the dentine girth, right? And a circumferential 3-dimensional ferrule with a minimum height which is around 3 to 5. And around minimum dentine range should be about 1.5 to 2 millimeters. And in this particular, if you have a proper 3-dimensional ferrule, restorative material will not contribute in any way. Now, for the sake of postgraduates, what is a ferrule and what is a ferrule effect? Now, ferrule and ferrule effect are two different things. Ferrule is a encircling band, a 360-degree encircling circumferential band of metal, which surrounds the parallel walls of the dentine, which extends coronal to the shoulder of the preparation. Your preparation is there and it extends coronal to the shoulder of your preparation is what is the circumferential, the 360-degree ferrule. Now, ferrule effect is the combination of ferrule effect is the preparation that we do on the tooth. The combination of the axial wall of the dentine and the circumferential basing of the tooth with the collar together becomes the ferrule effect. So we give a bevel on the tooth. And there's a small diagram. I couldn't get a proper thing. Now, where do we give, how should be the tooth preparation? For example, in this particular case, if you have adequate tooth structure around, that is the diameter of your dentine. In the after your post paste preparation, evaluate your dentine, see how much thickness you have. If it is 2 millimeters, minimum 2 millimeters, give a bevel on the outer edge so that you have a 1 millimeter of tooth structure left here. Otherwise, what happens is, if it's only 1 millimeter and you give a 1 millimeter bevel, then this part becomes very thin and this may lead to fracture. Or invariably, when you make a cast post, you have bubbles, air bubbles in that particular region, and it becomes very difficult to position the core the cast post on the tooth. So when you have adequate tooth structure, then you can give a bevel of 45 degrees. But when you do not have adequate tooth structure, it is only 1 millimeter or less, give a horizontal tooth preparation. Don't give a bevel. Okay, so that this is how it will be if you don't give a bevel. The core, you need a stable stop point so that it prevents the apical migration of the post. So that's the reason we give a stop here. So this will be her 90-degree bevel, and whereas this is a 45-degree bevel, wherein in particular, in case where you are going to use an noble metal alloys, then this bevel, extension of the metal you will be able to do a proper finishing of the walls. Otherwise, if you're going to use a base metal alloy, then you may as well give a 90-degree bevel. So this is for the okay. So now is the concept. Many people will not agree with the ferrule. They would say that we don't need a core ferrule. We just can do with a crown ferrule. This crown ferrule is enough not to give a core ferrule. It all depends upon individual perceptions. So for me, if I give a flat the thing, probably this can be considered as a no ferrule. I do not know. Okay, so another review of this ferrule effect and fracture resistance, wherein this particular article by Al-Omeri, it says that fracture resistance was improved if the tooth structure loss is limited, of course. A ferrule was obtained and a post with similar physical properties to natural dentine was used, and adequate techniques for post-loading and some restorations were used. So this gives us the factors that are responsible for fracture resistance. Another nice article by Elena Iluski was on ferrule effect, the literature review, wherein they state that you need to have a 1.5 to 2 millimeter ferrule around, which will have a positive effect on the fracture resistance. Of course, if you can't have a full ferrule, at least an incomplete ferrule is better than a complete lack of ferrule, right? And if there is not enough ferrule, then it is better to do an orthodontic extrusion rather than a surgical crown lengthening. Okay, so another article wherein they have compared cast post was a fiber post, and they concluded that both concluded that cast post indeed had higher fracture resistance than fiber post, and this was in 2013. I think then this they can have a review later on also, but the catching point here is, or the glitch here is that whatever failures happened with cast post, though it was this thing, whatever failures happened, they were catastrophic in nature. That is, there was a vertical root fracture wherein the tooth had to be extracted. Whereas when fiber post fractured, these teeth were more favorable fractures wherein they could be repaired. So this is a nice article. Another one is on influence of ferrule post system and length of biomechanical behavior of endodontically treated teeth, wherein they have taken 80 bovine teeth and they have done it in FEA analysis, and they have done with different cast post and fiber post, different length, 12 millimeters, 7 millimeters, and also adhesive or non-adhesives. adhesive, and in the absence of ferrule, the use of glass fiber post is the choice. And 7 mm cast post actually, post and core, produced higher rate of failure rather than longer post. So post length influenced only the cast post strength distribution, and the ferrule group always showed better stress distribution and more fracture resistance. Now, one more, I would rather end this thing about posts with one article which I very like it very much. Our own Dr. Kavita ma'am's article with her then student Dr. Ambika, wherein they have taken a natural tooth, drilled it, and using CAD/CAM technology, and they have drilled it into a post and used that human dentine as a post for the tooth. And they have suggested that this human dentine can actually serve as a post material. So I think this is one promising aspect, and she has to tell us whether she's continuing with that more with more studies. Moving on to the final part is the restorations. Now here we are talking mainly of badly broken down teeth, so it will be generally of and direct composite restoration, of course, can be done. And with nowadays we have nice fiber, short fiber reinforced composites. The composite technology is improving day by day. So the adhesive concepts are improving day by day. So we can have better options now. And of course, indirect, we can all go in for inlay, onlay, and overlay. Now, because of this adhesive options that are coming in, there is a difference in inlays and onlays. We used to learn as inlays as being an intracorneal restoration with one or more cuspal coverage, but not all cusps. Whereas onlays will be an intracorneal restoration with all the cusps covered. But now it has changed. Now it is inlays are only intracorneal restoration without any cuspal coverage. Onlays become an cuspal one or more cusp covered will become an onlay in case of adhesive onlays. And overlays is the concept that has been, indicative of restorations both with an intracoronal or otherwise also. These are called overlays. And of course, endocrowns, wherein it takes the retention of the pulp chamber. Now, mainly there is a lot of, not, I would not say controversy, but lot of variations in the use of whether to use a post, whether what type of restoration to use, and each have their own individual perceptions. Now, the main reason for that is because of the type of the tooth that we are considering. Suppose in anterior tooth, even if the tooth is intact, if there is a deep bite, because there is more of shear stresses that these teeth encounter, there you need to have even if the tooth is intact, I would prefer to have a post placed inside the root canal, and then do a restoration alone. With you need not even give a crown. In case of premolars severely, we have cervical stresses are more. So it's more of an flexure type of stresses. So in case where you have a class 5 cavity in a premolar intact tooth, then it's better to give a post and do a restoration alone. Whereas in molars, even if there is an extensive loss of tooth structure, wherein you can even have no walls also, because the stresses on molars are mainly compressive in nature, you can do without a post. So there is a lot of controversies which happens, and of course now the concept of giving a crown has almost I would say very negligible, very minimal in case we have to replace a crown or probably a tooth structure loss, total loss of tooth structure, and then you need to give a circumferential. All the margins needs to be at the gingival level. So otherwise, giving overlays is more, when you talk about adhesive overlays, it can be indirect composite, it can be even ceramic on overlays. Now, endocrowns is what is a latest, I would say, latest type of post-endodontic restorations that have been being introduced by Pisses and Bindle in 2005, and this is a case report that we actually published in Journal of Operative Dentistry and Endodontics. And before I finish, I have a couple of there's a few more slides. This was done in our department with fiber reinforced composite, that is Everex posterior, which by GC, wherein this was used as an post-endodontic restorative material and compared with two conventional composites as a core buildup. And we found a very favorable result with the short fiber post. And it can be used as even as a post. And we have another this thing wherein we are going to use this as a instead of a post, we are using this in the post space, and doing a restoration and seeing how the effect is going to be. This is one clinical case of mine which I did with the fiber reinforced post, with the fiber reinforced composite. The only thing is that it cannot be placed in the occlusal level. You need to give a covering of conventional composite. This was in 2015, then 17, and this is 18. The patient keeps coming with teeth after teeth. Now, one grossly mutilated tooth, almost one part is missing. This is by Dr. Shibu Sridhar from Cochin. This is an amazing job he does. And see the level of perfection in his work. Now the proper removal, proper preparation of the tooth, isolation in a proper way, and bonding is what makes the a face to the eye, actually, I would say, and absolute coronal and apical seal that you obtain. And this is one case which we tried doing some heroism. One case of from our student tried to patch up this. This was little subgingival, but without removing the fragment, we tried to do some reattach it and place some flowable composite, did a build up, and fiber reinforced composite. But I think this patient then came back about, though it was good for some time, it didn't last long. It lasted for maximum 9 months, that's all. And the patient came back and we have to had it extract. So you can always think of, some ways in which you want to retain the tooth, but not to a level where for sure that this tooth is not going to last for more than a few months. You can always tell the patient that you have to have the prognosis. You need to talk with the patient, tell them, and if they are willing to go ahead, you can always do that. But generally speaking, whenever we do an endodontic treatment, it should not only have an apical seal, but also a coronal seal, so as to obtain a restoratively viable endodontically treated tooth. And such a complete seal of the canal or canals right from the apical to the coronal is what we need to accomplish. I'm so sorry that I took up almost 15 minutes of your time, but I'm very thankful to Dr. Smita for giving me this opportunity, and I hope it was useful to all. Thank you very much.
Thank you, Mahalaxmi madam. It was a beautiful, I should say, it was a beautiful journey of bad management of badly broken down teeth from pre-endo to post-endo, and with so much of detailing, of course. There are many questions, but I will just try to take up few because of lack of time. Yeah. First question is that what is important, crown or a ferrule?
Yeah, ferrule or a crown. Yeah, ferrule is important, definitely. Now,
Okay.
that is the thing that you need. Ferrule is nothing but a circumferential amount of tooth that is around the tooth. So, because of that, there is a lot of controversy, the ferrule effect. That's the reason why we need ample tooth structure around. Say, suppose the tooth is broken totally at the cervical level. If you can get somehow by crown lengthening or by extrusion, if you could get about 1 millimeter of tooth around above the, above the gingival level, for something to hold on to, that is enough.
Okay.
So, ferrule is important. Crown, I would say, I'm assuming it is not the natural crown, but the crowns that we give. Then
Yes.
these crowns definitely are not important at all.
Okay, okay, thank you. Now, what are the bonding strategies of subgingival margins? Because most of the time in badly broken down teeth, we will face
Please.
this problem. Yeah.
For me, ideally, I would say that all the margins should be brought supragingival, irrespective of whatever material we use. So because one thing is that every tooth margin needs to be cleaned by the patient. So it has to be
Okay.
kept, cleansed. It has to be maintained. So
Yeah.
subgingival margin cannot be maintained by the patient. And you cannot expect the patient to use a floss, or you can use a toothpick to clean up that area regularly. And I'm sure we ourselves will not do it. So it has to be brought subgingival. So there is no way you can get away with some restorative materials that are, not so moisture sensitive, I would,
Friendly.
but you definitely cannot do any restoration subgingival. You could do, that is what margin elevation, deep margin elevation. The all the concepts were there. They're just been given a different name. That's all. So that what I said. No, that anything that we do, we need to think in terms of how it is going to stay, and where it is going to stay, and how it is going to be maintained. So I would suggest that any such subgingival margins needs to be brought. So supragingivally, you do a gingivectomy, you do a bone lengthening procedure based on whether biologic width is compromised or not. But please do it.
Yeah, I think that's a very valid point which you mentioned about the margin, because whatever is the material, there are limitations to it, and supragingival will give us the best results.
Yes.
Next is, what is the minimum? Actually, you have already cleared it throughout the lecture, but I'll just put it. The minimum amount of tooth structure which can be restorable. Is there something like this? I mean,
Yeah. See, that's what I'm saying.
yeah.
I'm just assuming maybe the total amount of tooth structure, maybe 1 millimeter above the gingival crest, even if you could get, or sometimes even that will be covered with gingiva. So you just see where exactly is your, that is where we need to be a little more like a periodontist as well. We need to check around the tooth how much of, how much of tooth structure is actually visible, because there may be chances that gingival overgrowth will be there. So it has to be an interdisciplinary approach. First you take care of the gingiva will take care of the tooth. So 1 millimeter above the tooth is enough. In case of anteriors, you could give a nice fiber post. In case of posteriors, you can give a nice core build up. It will still withstand, and an adhesive onlay will work.
Will work. Yes. And one last question, I'll just put it from my side. That can you tell us the tips for MOD cavities, especially for premolars? Because I think we come across many a times where there is a MOD cavity, and it gets a bit difficult for us to manage.
First thing you have to see is the periodontium. Okay, I'll go a little differently. First thing you have to see is the periodontium. You have to see how much of flexure that tooth is going to bear. See, if it has a good periodontal support, then the amount of stresses that is going to be there on the cervical area will be much lesser compared to a tooth which is compromised periodontally. There'll be a lot of flexure. So the more the flexure you have, the more the stresses will be there on the tooth, right? So that you have to see first. Sometimes MOD cavities alone, I'm assuming MOD cavities with access cavity, right?
Yes, yes,
Yeah.
yes, post-endo.
So what we need to do is, in such cases, already there's an MOD cavity. You don't need to do a crown preparation. The best thing would be to give a post, right?
Okay.
And then do the restoration of the thing. You can do a direct restoration. You can do an indirect restoration. any
restoration.
adhesive restoration should work
Yeah.
much better than any non-adhesive, because the point is here, any non-adhesive restoration in terms of metals, or even I would say even zirconia, I would not go in for, because zirconia is not it's a metal basically.
Yeah,
Though it's
yeah,
color,
true.
it's a metal. It's not a ceramic in any way. Though it
Yeah.
looks ceramic, it's not a ceramic. So I would rather go in for an adhesively luted restoration or a direct
Yeah,
restoration in
yeah.
that matter.
Yeah, which will have a better flexural strength.
Yeah, then post will actually help in in transmitting the stresses even
Forces.
down into the root.
Yeah, true. Okay, okay. So that was really nice.
Thank you
I
so much,
think,
ma'am.
yeah, I'll just
Yeah.
over to Dr. Smita.
Thank you so much, ma'am, for such an extensive lecture on how to manage the badly damaged teeth.
I'm so sorry I overshot short.
No issues, ma'am. No, it's our pleasure. And thank you for accepting our invitation. And I would request Dr. Sucheta, ma'am, to hand over the certificate and memento to the speaker.
Madam, virtual, virtual token of love with smile.
Thank you so
Thank
much.
you so much. Yeah.
Thank you, Sucheta. It was an honor to have you as my
Yes.
moderator. Thank
Yeah.
you. And
Thank you.
sorry to Mamta and Mohan for taking over their time.
That's okay, ma'am.
It was a vast topic as it is.
I am not. I should have said a disclaimer that my lecture is not complete at all in any way. Thank you so much, Smita.
Thank you, ma'am. Welcome. Thank you so much, ma'am, for accepting our invitation and being a moderator. It was a pleasure.
My pleasure. Yeah. It was a great pleasure too.
Thank you, ma'am.
Okay.
Now we conclude the session.